Good afternoon, everyone. My name is Min Kim, and it is a great honor and pleasure to participate in this wonderful meeting. And I'd like to personally thank AIOC for their very kind invitation. Today, I'd like to speak about the formation of macular hole after vitrectomy, their clinical features, risk factors, and treatment strategies. These are my financial disclosures.
Macular hole, as you all know, is formed as a result of interactions between various forces on the fovea, mainly from anterior-posterior and tangential traction by the vitreous.
And for the treatment of macular hole, surgery is usually performed to relieve these tractional components through vitrectomy, with or without ILM peeling. But how do you explain the formation of macular hole even after vitrectomy? For example, this patient initially presented with a MAC-off retinal detachment and received vitrectomy, but still ended up developing full-thickness macular hole. Secondary full-thickness macular hole after vitrectomy is a rare surgical complication with a reported incidence of up to 1.9%, and its contributing factors to its development in the absence of intact vitreous is not well understood, and pathogenic mechanisms other than those for idiopathic macular hole may be involved. So this study was performed to investigate the clinical spectrum of a secondary macular hole that develops after vitrectomy and assess the treatment outcomes, and to identify the risk factors that contribute to the development of secondary macular hole, and also determine the predictive factors for long-term visual prognosis. This was a retrospective case series, and the inclusion criteria is as follows. A total of 6,354 consecutive patients who underwent primary vitrectomy were initially screened, and those that developed a post-op secondary macular hole were eventually included in the study. And those patients who had undergone initial surgery for macular hole were excluded from the study. 38 eyes of 37 patients were identified to have developed secondary macular hole out of total of 6,354 cases that underwent vitrectomy. This was an incidence of 0.6%, and the mean age at the onset of macular hole development was 57.1 years old, and the median time to macular hole diagnosis after vitrectomy was 2.3 months, and the average axial length was 25.1 millimeters, and 48% of the patients had a longer axial length, greater than 26 millimeters. And the most common primary diagnosis for the initial vitrectomy were rhegmatogenous retinal detachment, followed by secondary epiretinal membrane and vitreous hemorrhage. There were also a few cases of idiopathic epiretinal membrane, lamellar hole, submacular hemorrhage, and vitreomacular traction syndrome.
Coexisting pathology and imaging features prior to initial vitrectomy are as follow. Epiretinal membrane was detected on OCT in 58%, and vitreous was also seen attached at fovea in 58% of them. Vitreous hemorrhage was noted in 29%, followed by retinoschisis in 13%, lamellar macular hole in 11%. Also, 8% of the patients had a past surgical history of MAC-off retinal detachment. Adjuvant surgical procedures performed in addition to vitrectomy for the initial diagnosis are as follows. ILM peeling in 44% of the eyes, pneumatic tamponade in 42%, silicone oil injection in 32%, and sclerobuccal or encircling in 13% of the eyes.
The average macular hole size on preoperative OCT was 544 microns, and the presence of epiretinal membrane on OCT was noted in 50% of the patients. And for the treatment of secondary macular hole, ILM peeling was performed in more than 80% of the patients. And if there were no ILMs remaining, ILM transplantation was performed, and either silicone oil or a gas tamponade was performed, and the closure of macular hole was achieved in 94% of the patients. At post-op 24 months, the average visual acuity was 20/86, and 47% of the patients improved at least 3 lines of visual acuity. The majority of the patients improved at least 1 line after macular hole closure. And the multivariable analysis of surgical and visual outcomes were performed, and the factors influencing a 3-line visual loss by the most recent follow-up were best corrected visual acuity at pre-op and post-op 3 months, as well as axial length greater than 28 millimeters. And the factors influencing the need for multiple surgeries for macular hole closure were having a history of macular off retinal detachment, and macular hole size or the presence of perioperative epiretinal membrane were only significant in the univariate analysis. This is the largest case series of secondary macular hole published so far, and we speculate the iatrogenic traction created during the induction of PVD, epiretinal membrane removal, or the ILM peeling, or the presence of residual recurrent epiretinal membrane may be involved in the development of the secondary macular hole. And previous studies consistently showed that there was a trend of macular hole formation after repair of MAC off retinal detachment, and also the association of secondary macular hole with high myopia has also been found in previous studies. In conclusion, secondary macular hole occurs rarely, with an incidence of 0.6% at 2.3 months after vitrectomy in our case series. And it occurred most commonly after vitrectomy for retinal detachment. And those patients with an axial length greater than 28 millimeters may have limited visual prognosis after vitrectomy for macular hole closure. And those with a history of MAC off retinal detachment may require multiple surgeries for secondary macular hole closure.
So then, what are some of the treatment options that we have for closing macular hole, even after the vitreous and ILM are already removed? Well, we can use the following surgical options to try to close the secondary macular hole. We can consider performing autologous ILM free flaps, amniotic membranes, lens capsules, autologous scleral flap, or even autologous retinal free flaps. Well, these surgical options may sound quite easy to perform, but for beginning retinal surgeons or surgeons with not so much experience in dealing with these surgically challenging situations, it may not be so easy.
So I'd like to introduce a modified simple technique for ILM free flap transplantation in macular hole surgery. I call this technique the PFCL peel technique. This will help you overcome some of the surgical difficulties while improving manipulation and retention of the ILM free flaps during macular hole surgery.
The PFCL peel technique for ILM free flaps in recurrent or persistent macular holes. A woman in her mid-60s presented with worsening central vision in her right eye. Her BCVA was 20/100. Fundus examination and OCT showed a very large, full-thickness macular hole. She had a history of attempted macular hole repair at another center nearly 2 years ago. The provided OCT images showed that the initial surgery failed and her macular hole remained persistent. She agreed to undergo additional surgery at our center using our modified ILM free flap transplantation technique. Autologous ILM free flaps are comparatively easy to obtain, but the technique is surgically and technically challenging owing to the difficulty in stabilizing and manipulating the thin flaps. PFCL, or viscoelastic assisting techniques, have been reported, but the techniques as currently described remain demanding. Injection prior to peeling will result in difficulty in creating the flap itself. And in cases when injection is done after flap creation, there is high risk of spontaneous flap loss, or the flap may refuse to go into the PFCL bubble and float on the bubble's surface. Thus, we introduce the PFCL peel technique. A small PFCL bubble is injected over the fovea to protect the exposed RPE. Afterwards, ILM is stained using ICG dye. We can then identify the remaining ILM and plan for free flaps. The planned ILM flaps are first partially peeled to create edges that can later be easily grasped. This first peel is important as it enables regrasping even if the edges were later to be flattened under PFCL. Then additional PFCL is injected so that the entire posterior pole and all planned flaps are fully covered. Finally, the previously peeled ILM flap edges can then be easily visualized and grasped under the PFCL without having to then create the ILM flaps under the influence of heavy liquids. Free flaps can be efficiently completed and placed within the macular hole. The high density and high interfacial tension of PFCL stabilizes the ILM free flap once it is released. And enables multiple regrasping of ILM flaps for proper placement within the macular hole if necessary. Under the PFCL bubble, there is no need to fear the flaps floating away and flittering out of view. Gentle massaging of the macular hole margins may improve outcomes and retention of ILM flaps. Fluid air exchange is first performed, followed by careful and deliberate PFCL air exchange. While performing fluid air exchange, care must be taken to prevent dislodging of the ILM flap by carefully placing the extrusion tip away from the macular hole. The posterior pole can be carefully rinsed with balanced salt solution to ensure that PFCL is fully removed. At post-op week 1, we can confirm on OCT that the macular hole was successfully closed.
So this modified simple technique for ILM free flap is an easy to perform, efficient variant sequence that can easily create and stabilize the ILM free flap for proper placement within the macular hole. We believe that this technique can be utilized readily even for surgeons with little experience in dealing with recurrent or persistent macular hole. Thank you for your attention, and once again I'd like to express my gratitude for the wonderful invitation to this meeting. I hope to personally meet each and every one of you in the near future meeting. Until then, take care and goodbye.